Bismillahirrahmanirrahim. Today's lecture is about identifying an acute myocardial infarction on the 12 leads ECG. Identifying an acute myocardial infarction on the 12 lead ECG is the most important thing you can learn in ECG interpretation. Background: in anterior myocardial infarction, determination of the exact site of the left anterior descending artery, which is called in short LAD, occlusion is important because the more proximal is the occlusion, the less favorable is the prognosis. In acute anterior myocardial infarction, shortly called AMI, the site of occlusion in the left anterior descending artery, coronary artery, is related to the extent of the myocardial necrosis and prognosis. Electrocardiographically, anterior myocardial infarction is classified as anteroseptal, anterolateral, and apical. Blood supply of heart: we have two main arteries, the left main circumference artery and the right circumference artery. The left main circumference artery is then divided into the left anterior descending artery, the left circumference artery, the septal artery, and diagonal arteries. The right coronary artery is divided into the posterior descending and much more. Anterior ST segment elevation myocardial infarction type 1. There are 5 basic acute myocardial infarction ECG patterns that carry a high mortality if not treated rapidly. An anterior STEMI ST segment elevation myocardial infarction is usually from acute thrombotic occlusion of the left anterior descending coronary artery, also known as the widowmaker, cause more deaths in men. That's why it is called widowmaker. The anterior leads are V3 and V4. However, it is common for the septum and or lateral wall to be involved during anterior myocardial infarctions, as the left anterior descending coronary artery supplies septal branches to the interventricular septum and diagonal branches to the lateral wall. The septum is represented on the ECG by lead V1 and V2, whereas the lateral wall is represented by the leads V5, V6, lead 1 and lead AVL. Thrombus in the proximal LAD. Proximal occlusion in the LAD result in massive infarction. The more proximal the occlusion, the more the number of leads that supply that display. ST segment elevation. Occlusion proximal to the first septal and diagonal branch cause ST segment elevation in V1, V4, AVL and lead 1, as well as reciprocal ST segment depression in lead 2, lead 3, AVF, AVR and AVR. New right bundle branch block is common. This is the left anterior descending artery. It is divided into 3 parts: the proximal part, the medial part and the inferior part. This is the main coronary artery. This is the proximal part. Here is the medial part, and this is the inferior segment of the left anterior descending artery. More proximally, when the artery is occluded, more branches are involved and more leads in the ECG are affected, or there are changes in many leads of the ECG graph. Thrombus in the proximal LAD. This is the proximal left anterior descending artery, and when in this area there is thrombus, it causes ST segment elevation in lead V1 and V4. When there is thrombus in this area in the proximal portion of the artery, it causes ST elevation in V1 and V4. You can see that here is the ST segment elevation in these two leads, as well as reciprocal ST segment depression in 2, 3 AVF and AVR. Here you can see that in lead 2, lead 3 and AVF leads there is ST depression. This is the proximal portion, and when there is obstruction in this area, it causes elevation in V1 to V4 and reciprocal depression in 2, 3 and AVF leads. LAD occlusion proximal to both the first septal perforator and the first diagonal branch shows characteristic ST elevation in AVR in V1, V4 and ST segment depression in V5, V6 and abnormal Q wave in AVL. If the obstruction is here, when the obstruction is proximal to both the first septal artery, this is the first septal artery and this is the first diagonal artery. So the ECG pattern is like this. There is ST elevation in AVR. You can see that here is the ST elevation in AVR in V1 to 4. This is V1 and up to here. ST elevation is in AVR, V1, V2, V3 and V4. You can see the ST segment elevation in these leads, chest and limb leads. ST depression in V5, V6 and abnormal Q wave in AVL. You can see that there is a ST depression in the lateral leads V5 and V6 and abnormal Q wave in AVL. Here you can see that this is the abnormal Q wave in the AVL. Thrombus in the mid LAD. When the thrombus is in the mid LAD after the septal branch, the diagonal branches may or may not be involved. When this obstruction is proximal to the septal branches, as the septal and diagonal branches are close to each other, so the diagonal branches may involve or may not be involved in this condition. But if the obstruction is proximal to the first septal artery, if this is the case, then the ST segment elevation will be in V3 to V6 and not the septal leads. You can see that the septal branch is spare or it is not involved in the obstruction. Here the blood supply is maintained. The ST segment elevation will be in V3 to V6. Here you can see from V3 to V6 you can see the ST segment elevation and not the septal leads. Septal leads are V1 and V2. Here in V1 you can see there is no elevation of ST segment in septal leads. Type 2 inferior ST segment elevation myocardial infarction. This myocardial infarction ST segment elevation in the inferior lead 2, 3 and AVF and only require 1 millimeter in two contiguous leads. There is usually reciprocal depression in lead 1 and AVL, which help to distinguish this from pericarditis. In anterior MI, the ST segment elevation is usually concave upward. ST segment elevation. There is elevation in lead 2, lead 3 and AVF. You can see that this is lead 2, lead 3 and AVF. Here you can see the ST segment elevation. And there is reciprocal depression in lead 1. Here you can see the reciprocal ST segment depression in the lead 1. And ST elevation 2, 3 and AVF is concave. This is concave in nature, not convex but concave in nature. Here you can also see there is ST elevation in lead 2, 3 and AVF and reciprocal depression in lead 1 and AVL. The same is the case in this ECG graph also. ST elevation in 2, 3 and AVF and their depression in lead 1 AVL. This is the lead 1 and this is the AVL. You can see the ST depression. The criteria for inferior ST segment elevation is at least there must be contiguous elevation of 1 millimeter in 2 consecutive contiguous leads. Right ventricular myocardial infarction. ST segment elevation of more than 1 millimeter in lead V4R with an upright T wave in that lead. You can see that when there is right ventricular myocardial infarction, there is ST elevation which is more than 1 millimeter and there is also an upright T wave in the same lead. This sign is really present more than 12 hours after the infarction, disappear after 12 hours of the infarction. ST segment elevation in lead V1 in association with ST segment elevation in lead 2, 3 and AVF with greater elevation in 3 and 2 is highly correlated with presence of right ventricular infarction. When there is ST elevation in lead 2, 3 and AVF, this is lead 2, this is lead 3 and AVF. There when there is ST elevation in these 3 leads with greater elevation in lead 3 more than 2. You can see the elevation is more in lead 3 than the lead 2. It is highly correlated with the presence of right ventricular infarction. Right ventricular infarction is there is a 1 millivolt ST segment elevation and in V4R, lead 2, lead 3 and AVF. Other example of acute inferior myocardial infarction with right ventricular involvement. You can see the lead 2, lead 3 and AVF. In lead 3, elevation is more than the lead. Here V4R, there is elevation with the upstroke of the T wave. The T wave is also elevated in V4R. Now this is the summary of obstruction in the lateral anterior descending artery in various spot and its location. So lead with ST segment elevation. When there is ST segment elevation in V1, V2, the infarction is septal and the obstruction is in the proximal portion of the LAD. When there are changes in the V3 and V4, the infarction is anterior, the myocardial area is anterior and the artery affected is left anterior descending artery. V5, V6, the infarction is in the apical area and distal portion of the left anterior descending artery is affected. If changes are in lead 1 and AVL, this is lateral infarction, and the obstruction is in the lateral circumference artery. If the changes are in lead 2, AVL and lead 3, this is inferior infarction. 90% involvement is right coronary artery. If changes are in V7, V8 and V9, this is a posterior lateral infarction, and the affected artery is right coronary artery or left circumference artery. There are reciprocal ST depression are frequently evident in V1 and V3. If you want to know more detail, you can pause the video and study this slide also. Now type 3, posterior ST segment elevation myocardial infarction. The posterior wall is supplied by the posterior descending artery. The posterior descending artery branch from the right coronary artery in 80% of the people, those who are right coronary dominant. Therefore, occlusion of the right coronary artery can result in both an inferior STEMI ST elevation myocardial infarction and a posterior myocardial infarction as well. This is the right coronary artery, and these are the posterior branches which supply the posterior wall of the inferior wall of the heart. So when there is obstruction in the right coronary artery, the inferior portion of the heart is affected, and this is called posterior ST segment elevation or posterior ST segment elevation myocardial infarction. If the supply is from the right coronary artery, so this is called, sometimes it is obvious on the ECG when a posterior MI accompany an inferior STEMI, but it can also occur all by itself. So there are three conditions. In one condition, the supply is by the right coronary artery. This is called right coronary dominant. In 10%, there is the supply of the posterior wall is by the left coronary artery. So this is called left coronary dominant. And a third case is both the left and right coronary artery supply branches to the posterior wall. The ECG criteria to diagnose a posterior MI: ST segment depression, not elevation in V1 and V4. In posterior MI, there is ST segment depression in V1 and V4. Turn the ECG upside down and it would look like a STEMI. The ratio of the R way to the S way in lead V1 or V2 is greater than 1 mm. This represents an upside down Q way similar in region to the ST depression instead of elevation. ST segment elevation in the posterior lead of a posterior ECG leads V7 and V9. The posterior ECG is done by simply adding 3 extra precordial leads warping around the left chest wall towards the back. These extra leads are attached to the ECG and placed on the back of the below the shoulder blade in this position. The ECG criteria to diagnose a posterior MI. Here a patient with an isolated posterior MI. There is no inferior involvement here. It would have been nice to see more ST depression in V. You can see that in posterior MI in V1 and V2 there is ST depression. And if you will upside down the ECG, it will look like an ST elevation. Here you can see that in V1 and V2 you can see that it look like ST elevation when you will turn upside down the ECG paper. And in V1 the ratio of RS is quite high. You can see that the R wave is prolonged and is much lengthier than the S wave. The same patient with a posterior ECG tracing leads V7 to V9 were added. There is not quite 1 mm ST segment elevation in these posterior lead, but you can see at least some slight elevation. These are lead V7, V8 and V9. In posterior MI, when these extra leads are added to the ECG machine, you can see that there is a slight elevation of the ST segment in these leads in 7, 8 and 9. Below are two examples of ECG tracing with both inferior STMI and posterior involvement. In inferior, there are changes in the 2, 3 and VF. In posterior, you can see that there are T inversion in V1, V3 and V6. Type 4 acute MI with right bundle branch block. A right bundle branch block does not stop us from detecting STEMI on an ECG. Here is the anterior STEMI with a right bundle branch block. In this ECG graph we have right bundle branch block and also the anterior myocardial infarction or ST elevation myocardial infarction. You can see that this is the right bundle branch block. QRS complex is more than 3 small square R, and here in V4, V5 and V6 there are ST elevation. So this type of infarction has occurred with right bundle branch block. Here is an inferior MI with right bundle branch block on ECG. Inferior STEMI with right bundle branch block on the ECG. Note the reciprocal depression in lead 1 and AVL. There is a right bundle branch block. You can see that QRS complex is wider and sludge away. With association with right bundle branch block, we have inferior MI. The inferior myocardial infarctions changes occur in lead 3 and 2 in AVF. Thank you. Please subscribe the channel and on the bell icon for updates.